Welcome back to ST3 Hacks, and in this episode I'm going to be talking through peri-lunate and lunate dislocations. These are relatively uncommon injuries, but they're very high risk and time critical. In interviews, they're often used to see whether you recognize an orthopaedic emergency and whether you know what to prioritize early on. How I frame peri-lunate and lunate dislocations. I think we should start by understanding the mechanism, urgency, and the risks, particularly neurovascular compromise. And if those are right, everything else kind of tends to fall in place in this station. So let's go through the pathoanatomy. These injuries follow a predictable pattern of ligament disruption, which is described in a posh word called Mayfield progression. And if you drop this in, you're already off to a good start. So this is a lesser arc injury pattern with sequential ligament failure. So you start off with the scapholunate ligament getting worse, then the capitolunate ligament being disrupted, then the lunotriquetral ligament, and finally the dorsal radiolunate ligament, which results in a true lunate dislocation. So a lunate dislocation requires that fourth ligament to also go. So if you have that, you've kind of gone through all of the Mayfield progression. In contrast, just for knowledge, greater arc injuries involve one or more associated fractures around the carpus. Moving on to the mechanism and carpal alignment. In a perilunate dislocation, the lunate stays relatively aligned with the radius, while the rest of the carpus dislocates dorsally. There's loss of the normal columnar alignment between the radius, lunate, and capitate, with dorsal translation of the distal carpal row and metacarpals relative to the long axis of the radius. In a lunate dislocation, the lunate itself dislocates in the volar aspect through, note it down, the space of Poirier, which lies between the long radiolunate ligament and the radioscaphocapitate ligament. So the space of Poirier is like a really posh thing you can drop in and always looks good. Radiographic signs. So you should talk through the x-rays very carefully. And these injuries are commonly missed. So on the PA view, I look for disruption of the Gilula's lines, all three of them. And these are going to kind of blur in your mind, but hear them slowly. The proximal border of the proximal carpal row, the distal border of the proximal carpal row, and the proximal border of the distal carpal row. And all these three should be like nice and smooth. Next, something to know is the Terry-Thomas sign, indicating scapholunate diastasis, a gap between the scaphoid and lunate. Terry-Thomas apparently was like some celeb who had missing teeth, so a gap in his teeth is what this sign looks like. The scaphoid signet ring sign, which is caused by scaphoid flexion and rotation. And then there's also the pizza slice or pie-shaped lunate sign, which suggests that the lunate is loose and has rotated. On the lateral view, alignment is really key. The radius, lunate, and capitate should normally be collinear, and any loss of this relationship should raise strong suspicion. Key concerns and red flags. This is an orthopaedic emergency, okay? And up to 25% of patients have median nerve compromise. So this is something to actively look for and state clearly in an interview. They're usually high energy injuries, so you have to approach them in an ATLS principle manner and actively look for other injuries. So you should, kind of say, my overall approach is guided by the ATLS algorithm, early recognition, urgent reduction, neurovascular protection, and early senior involvement. And if there's nerve involvement, you can also mention the BOSE guidance and peripheral nerve injuries. So like with any station, you start with a triple assessment. Your history, mechanism of injury, Socrates, ample history, relevant social history, occupation, hand dominance, and smoking status. The examination, look, feel, move manner, but movement is often very limited and painful, so you should prioritize a full neurovascular assessment, especially median nerve function, sensation in the radial 3.5 digits, motor function including thumb opposition, and assessment for swelling, deformity, and any skin compromise. Moving on to investigations. Standard investigations are the PA and lateral wrist radiographs, and they're kind of normally given in the station. But a CT imaging can be very useful if you're unsure, or they can help for surgical planning later down in the management section if you're taking them to theatre. Okay, so then initial management. This is where you should slow down and structure because it shows urgency without panic. Okay, so you need to kind of say that this is a really emergent situation, but it needs to be organized and you need to come across as really balanced and in control. So you should say, I would inform the on-call consultant early, explain my concern about a peri-lunate or lunate dislocation, outline my plan for urgent closed reduction and the possibility of theatre if reduction is unsuccessful. I'd then place the patient in finger traps and attempt a closed reduction using the Tavernier maneuver. okay? Finger traps and Tavernier maneuver, really important things. This basically involves longitudinal traction, gentle hyperextension of the wrist, pressure applied with the thumb to the volar aspect of the lunate, followed by flexion of the wrist to complete the reduction. After reduction, you can drop in these golden pearls. I'd immobilize the wrist in a sugar tongue cast and reassess neurovascular status. Moving on to definitive management, it's almost always operative. So you should say, I'd consent the patient for manipulation under anesthesia, possible open or closed reduction, percutaneous pinning or open ligament reconstruction, and carpal tunnel decompression if there are any median nerve symptoms. Saying this is like standing out as a candidate, so I'd definitely mention the carpal tunnel thing. Reconstruction often requires a dual incision approach to address both the dorsal and volar ligament injuries. But I mean, this is getting into hand surgery realm, and you don't really need to know it. But here you go. I think it's also important to be aware of the complications. So the one worth mentioning is the transient ischemia of the lunate. This occurs in about 12.5% of cases, usually presenting 1 to 4 months after injury. On the X-ray, the lunate appears radiodense. It's usually self-limiting, but it's important to recognize so it isn't mistaken for avascular necrosis. If you remember one thing for peri-lunate and lunate dislocation, it's this, that you recognize them early, protect the median nerve, and always involve senior help without delay, okay? So that's it for this episode of ST3 Hacks, and see you in the next one.